So now coming to the discussion part. So what is the effect of fibroid and fertility? We know very nicely that fibroid, if you are handling a patient that is like aged patient, a patient who has already completed the family, you must be well aware the Supreme Court has given a judgment right now that if you are doing any hysterectomy in patients below 40 years of age, you need to report it. Because nowadays the government is very strict about laws. Earlier, what used to happen in periphery and other centers, people used to just do hysterectomies, because the moment you are taking the patient for laparoscopic myomectomy, if you are having any complication to salvage the life of the patient, many times the gynecologist has to do a hysterectomy. So now you have to report it to the higher authorities, and many times if it is not justified, if you have not prepared the patient properly, then obviously you can land in a medico-legal negligence case. So it is very important for you to be very particular how you are doing the laparoscopic myomectomy. I'm coming step by step in it because it is very important, because in fertility patients, 90% of the fertility patients are complaining of fibroid. So in a patient with infertility, if he or she is having a fibroid, you are doing a lap myomectomy, and by any chance you have to land in a hysterectomy, then you are in more trouble, because the patient will use that thing as a tool. But obviously in a patient with menorrhagia, in a gynecological patient, obviously there is problem, but not so much as in a patient with fertility, because medico-legally you are more liable in these kind of patients. So what happens? Why this fibroid causes infertility? So there is greater distance for sperm travel, there is encroachment on tubal ostium, there is distortion of uterine cavity, there is vascular changes. The normal rhythmic uterine contractions, they are very important for the implantation to happen. So this gets interfered when there is a fibroid. There is impaired implantation because of this. There is abnormal endometrial maturation and alteration on oxytocinase activity, which is very important for the implantation process. So this is the FIGO classification. As you see, this is the submucosal fibroid. So they give it grade 0 when it is pedunculated at its intracavitary. This fibroid is the most easy to remove, because you can go hysteroscopically and you can just cut it from here and you can remove it. If you have taken all the pre-op, all the requisites have followed, believe me, you will never fall in any complication. In my 25 years of career, I have never landed in a hysterectomy while doing a lap or a hysteroscopic myomectomy. It is grade 1 if it is greater than 50% intramural. So in this, you see that it is greater than 50% intramural. This also you will go hysteroscopically. I'll be coming to that slide also. You don't need to put a laparoscope. Anyway, if initially you are doing it to be confident, you can just put a laparoscope from up to be diagnostic to see that you're not opening the cavity. But later on, when you have done many cases, several cases, you don't need to put that also if you're confident in your procedure. Grade 2 is greater than equal to 50% intramural. So now coming to others. So third one is it contacts endometrium. This is 100% intramural. Obviously, you cannot do it hysteroscopically. 4 is completely intramural. 5 is subserosal. It is greater than equal to 50% intramural. 6 is subserosal, less than equal to 50% intramural. 7 is subserocal pedunculated. You don't need to remove it. 8 is other, like specify, for example, cervical, parasitic, these kind of fibroids, cervical fibroids, broad ligament fibroids. There are hybrid leiomyomas also. This is 2 to 5 that they have given for FIGO. They are submucosal as well as subserosal, and each with less than half the diameter in the endometrial and peritoneal cavities respectively. So what is the indication of myomectomy in patients with infertility with intramural fibroid? First and foremost, there has to be a failure of 3 cycles of controlled ovarian stimulation and IUI after optimizing all other factors. There has to be a recurrent implantation failure. The intramural myoma has to be greater than 5 centimeters of size, and the intramural myoma has to be with submucous extension. So coming to submucous myomas, hysteroscopic myomectomy is the most accepted approach in patients with submucous myoma with infertility. Laparoscopic approach should be considered in patients with submucous myoma if 3 or more submucous myoma are there, or the submucous myoma of greater than 3 centimeters size, to reduce the risk of damage a large portion of the endometrial surface. And then when there is submucous myoma, when it is extending to the uterine serosa. So how do we do the history? And in patients who are not infertile, obviously that is very symptom based. When the patient is having problems of menorrhagia, the patient is bleeding excessively during her periods, menstruation, or the patient is bleeding continuously and she has to be replenished by blood transfusion, and the medical management is not able to suffice it, we go for laparoscopic myomectomies. Secondly, in patients who are having pressure disturbances, means the patient is not able to pass bowel, the bladder motions properly, the bowel motions properly, then also we go for laparoscopic intervention. Thirdly, the patient is having a lot of pain and discomfort and all the medical management has failed, then also we go for laparoscopic myomectomy. These is for patients who have already completed their family, and then we intervene in them. So the hysteroscopic myomectomy, the patient selection, it is limited to patients with FIGO classification type 0 and type 1 leiomyoma. Type 0 leiomyomas are entirely within the uterine cavity with no myometrial extension. Type 1 leiomyoma involve greater than 90-degree angle of the leiomyoma surface to the uterine wall. Type 2 leiomyomas involve greater than 50% myometrial extension. They, when viewed histoscopically, there is a less than 90-degree angle of the leiomyoma surface to the uterine wall. Some type 2 leiomyomas may be performed hysteroscopically, and expert surgical experience is needed. Key points. It is important to determine the distance between the outer edge of the leiomyoma to the serosa with ultrasound or pelvic MRI with and without contrast to determine if a hysteroscopic approach is feasible. But it is always better to get a pelvic MRI done with contrast. It gives you a much better precision and much better picture. It is advisable to exclude hysteroscopic resection of a leiomyoma that is within 1 centimeter from the serosal edge. Adherence to this guideline decreases the risk of uterine perforation. So as it is what I am telling you, because this is more towards, because at this time the practice is more towards, we have to be patient friendly, plus we have to be medico-legally also very sane. So if the myoma is within 1 centimeter from the serosal edge, I am again repeating it, then please don't go for a hysteroscopic resection, because otherwise it will lead to uterine perforation and you will have to put the laparoscope from up. Or if the patient bleeds too much, then you can go for hysterectomy also. That is very dangerous. The procedure recommendations are made to use intrauterine pressure of 70 to 80 mm Hg, which is approximately equal to the mean arterial pressure for the average patient. You need to know this, that why we keep the intrauterine pressure of 70 to 80 mm Hg when we introduce the trocar, why the pressure is so. Because the mean arterial pressure for the average patient is that much. The goal is to decrease the risk of intravasation due to high pressure. So what will happen when you give high pressure? So because if you have put the trocar inside and still you are not able to inflate the abdomen, it doesn't mean that you keep on increasing the pressure. So these are very practical points that a person who has done it practically only can explain you. These usually are not very much, these are very tricky things. So in this case, why this is not increased? Because this will risk of intravasation will be there due to high pressures and you will land in deep trouble. Secondly, hysteroscopic removal of leiomyomas can be accomplished with a hysteroscopic resectoscope, monopolar or bipolar devices. Increasingly, hysteroscopic morcellators are available and utilize saline as the distension medium and are more commonly employed for type 0 leiomyomas. Obviously, when you are using saline, you are having a low risk for any kind of embolism or any problem. So this is the way we do a hysteroscopic myomectomy using loop resectoscope. So we put it inside and then we cut it from here, we keep on cutting it, then we cut it and we come out. So if you are very clear, you see these bubbles coming out when we are doing it. You have to be very fast as well as you have to be very precise. Fast because the less the surgical time, the more it is good because the patient will recover more fast and less risk of any complication. So what are the complications that can happen? It can lead to fluid overload and electrolyte disturbance. Myomectomy carries greater risk because of the large blood vessels often found surrounding the leiomyomata. There can be air embolism. There can be bleeding complications, as I've told you. There can be perforation. There can be incomplete removal of fibroid. Or there is a need of conversion to laparoscopy or laparotomy. It also happens in many cases.